We did have a pre-planned specific subgroup analyses, and I would say broadly, for progression-free survival, transplant benefited everybody. The important point is there were certain subgroups in whom that benefit was less pronounced than others. And very interestingly, we saw it in several different unexpected places. We were very proud of the fact that in this study, we had the highest participation of African Americans in any phase 3 seen to date. It's around 20%. And interesting enough, in that population, compared to other racial groups, the benefit of transplant was less marked. The hazard ratio was just around 1, which was really interesting. And we don't quite understand why, but we're going to take a hard look at it. But you can conjecture that, if you've got a patient who's saying, I might want to keep transplant in reserve, I have family commitments, I have work commitments, there are things that make this more challenging for me right now. If you've got specific clues, that might help guide the decision making. And in that same spirit, what we showed was that if you had high risk disease, it was important to do transplant. That clearly was shown, but not all high risk is the same. That's the other thing we observed. This bucketing of high risk is clearly no longer valid because we saw different breakouts in different subgroups. So whilst these subgroup analyses were not powered to be definitive, they're certainly informative and hypothesis generating, so that was clear cut. I think in the context of a practice approach, what we also showed was that if you achieved a high quality response, if you achieved MRD negativity, regardless of which approach you had, you did well. So in a sense, these are clues that guide us as to how we can tailor our treatment options for patients.